We have our lab exam this week, and we will start it at 1 o'clock, like we did the last time. Doors will open at 12:45, close at 1 o'clock. If you're not in and ready to go, you don't get to join in. Okay? Same format as we had before. Okay, fill in the blank, I'll give you an answer sheet, and that's what you'll do. Okay? Study off your labs, your assignments, and the figures in the book. And we had our reviews, so hopefully everybody knows what we're studying. Okay? Are there any questions with what we're doing? Okay? There's also the end of course survey that is up. Okay? I think it's only open through this week. So any constructive criticism would be nice. Don't tell me you covered too much material or you moved too fast. Okay? We've got what we've got to cover. So unfortunately, there is a lot. And I realize that. Okay? But if there's something that you found maybe that would help future students learn better, something we could change in the labs or something I could change on the assignments. Maybe you found an assignment or something that you found really helped you, please add that in. I'm always looking to try to make this course better. Okay. Also YouTube videos. If you found some that really help, please send them to me or at least let me know. I can't always receive links on the TCC email, but at least let me know what they are. Because again, I'm here to try to get you guys through this course, and I'd love to see everybody get an A. In fact, I've had classes where everybody gets A's, because everybody works really hard and gets their stuff in and yada yada, so we all do it. Okay? That's my goal. I want to see you guys succeed. And, you know, I love when my students stop back and say hi, let me know how you're doing, what you did with your life after this class is always, that's why we teach, is to help you guys move forward in your life and your career. And I had my career and loved it, and I think back about people that helped me make my decisions or move forward in classes. And so that's what teaching is about. You know, that's why I do it now that I should be retired and sitting at home if I need it. So, all right. So if there's any questions, you know, if you guys want, anybody that does the online survey, or on-class survey, what do you call it, online, whatever it is, for the class, thing, 5 extra credit points, would that help? Okay. As long as you don't get on there and say, oh, she was a bitch and I hated the class. Okay, that doesn't help anybody. We all chuckle about it because, you know, I'm not here to necessarily be your friend, though I think it's fun if we do have friendships and we do hear from you in the future. I mean, I think that's always fun. But that's not my goal in life. Okay? My goal in life is doing flipping dog shit. Okay? Which we did really well this weekend. All right. Even though it poured out raining and it hailed in Kerala, go figure. Okay. At least I have washing our dogs. All right. So we've got the, we're going to talk a lot about what happens, things that affect pregnancies and birth defects. Okay. When we talk about the pregnancy, I think everybody knows we have 3 trimesters in here. Okay. And the first trimester is obviously the most important one. Unfortunately, a lot of times it's before a woman even knows she's pregnant. Okay? She gets halfway through the first trimester and then, uh-oh. Okay? And the reason why is because most of your really major cell divisions are occurring in this first trimester. Okay? And with that being said, any stress or drugs or nutritional deficiencies are going to affect the cellular division. Okay? And anything that puts stress on the cells and the cellular division The chances of mutations are there, okay? The chances of a cell not reproducing is there, okay? So this is the most vulnerable stage of the pregnancy to that kind of stuff. And in fact, it's estimated that over 50% of all pregnancies terminate in a spontaneous abortion, and the woman doesn't even know she was pregnant. All right? So, again, more than half of them will die in this stage. And again, these are 12 weeks, right? 12 weeks sessions, okay? So that's the first trimester. A lot of the organ systems are almost completed at that point, okay? Because by the end of the 8 weeks, all organ systems are present. Now, whether or not they're completed or not, okay? It is now considered a fetus at that point. Bones are even beginning to calcify. Skeletal muscles exhibit spontaneous contractions later to be felt by the mother, but at this point the thing is too small to actually be felt by the mother. The heart is started to beat about week 4, and it now circulates the blood. We'll talk about how that happens. Okay, the heart and liver are very large, forming a very big bulge in the chest area. And the head is nearly half the size of the entire thing. All right? So by the second trimester, 13 through 24, the organs are completing most of their development. Again, some of them are already completed by the end of the first trimester. Okay? But by the end of the second trimester, they're really going to be completed, except for a few. Got a few that don't. Okay? And this is where you can start to see anatomical detail with sonography. And if you haven't seen 3D sonography yet, check it out. It's just amazing. Okay, it's really cool to see. You get into the second and the third trimester and you do that 3D sonography. It's really amazing. Okay, I've seen some friends now that have had that done during their pregnancy, and it's absolutely amazing. Okay, so the chance of survival if they're born at the end of this trimester is possible, okay? But again, it's a little bit early, okay? So about 24, 25 weeks, it possibly can survive. The third trimester is 25 weeks till birth, okay? And this is where you get 50% of your growth is occurring during this time. Very rapid growth of the baby, okay? And then you're going to get a lot of the organs that aren't finished during the first or second trimester are going to finish up here, except for the lungs, okay? And that doesn't occur until we get done. The liver also doesn't finish up until right about birth, okay? You're considered mature at 35 to 37 weeks, okay? All right. So when we talk about twins, we have 2 types of twins, non-identical, dizygotic, or monozygotic, identical twins. The identical twins, this is when that embryoblast, the thing that's just a big ball of cells, actually splits into 2. They share the same placenta, and these guys are about 90% identical. There is still a little bit of a difference. I grew up with a lot of twins in our high school, okay, and we could always tell the differences. Sometimes the teachers couldn't tell the difference for some bizarre reason, okay, but we could. And in fact, I remember in like 4th grade, the teacher switched Jane and Jill. They were identical twins. They switched them, put them in different classes, and we were all like, well, what's Jane doing in this class? Jill's supposed to be in here. And the teachers are like, you guys knew that. Okay, they didn't look anything alike to us, but okay. My grandpa was an identical twin, and when my grandpa died, his brother came to the funeral, and that was really freaky. Okay, because they were identical until the day he died. Yeah, that was really freaky. Okay, my cousin was an identical twin. So I've had a lot of twins in my family, and in our high school there was a lot of twins. But these guys are about 90% identical. Dizygotic, this is when 2 eggs ovulate at the same time. They get fertilized at the same time. They have their own placenta. They're no more similar than just siblings. They just happen to be born at the same time. This is what we used to call fraternal twins, okay? Non-identical, okay? They're just like siblings. All right, so when we talk about the fetal circulation, the lungs are the last thing to develop, and I kind of talked about this when we talked about respiratory situations. So we've got really kind of the oxygen, carbon dioxide, all of that is taken out through the placenta, through mom's circulation. Okay, so we don't have a pulmonary circulation going on in this developing fetus. Okay, and we talked about this. We've got 3 circulatory shortcuts or shunts. Okay, and we've got the umbilical arteries are coming up out of the iliacs. Okay, and we're going to get the oxygen, nutrients returning to the mom through the umbilical vein. So everything is going to go actually through the placenta. Okay, we're also kind of bypassing the liver. Okay, because we don't really need it to function much at this point because mom, all the blood is going up through mom. Okay, and remember the liver does a lot of stuff. It detoxifies things. It does a lot of stuff. And so everything goes up through mom's liver. So we have really a bypassing of the liver called the ductus venosus. Okay, and this leads directly to the inferior vena cava and really back. Mom does all of the detoxing, all the paying attention to what's going on with the baby's blood, oxygenating it, sending nutrition over there, all that stuff. Okay, so we need to, the liver again is not really fully developed, it's not really functioning in the fetus. And then we've got the bypass of those lungs because they're obviously not functioning either. Okay, so when we go into the lungs, okay, we've got, and I've talked about this before, we've got a hole between the right and the left atrium. Okay, it's in that interatrial septum. What's a septum? Divider, right? It's in the divider between the 2 atrium. Inter, and between atrial septum, and that hole. So the blood goes from one atrium into the other atrium and then into the circulation. There is no atrium, ventricle, lungs back that way. Okay? It just goes atrium and into the other atrium. Okay? And it's called, okay, a foramen. What's a foramen? A hole. Okay? It's an oval hole. Okay? It's an oval hole. Ovale, oval hole. Okay? So you'll get it going from the right atrium into the left atrium. Okay, you'll get some blood going up into the pulmonary trunk, but basically it just goes back down into the aorta. There is no functioning lungs, so it just doesn't go that way. Okay, so the majority of it's going to go in through this direction. Okay, the lungs are really only receiving a little bit of blood, just enough to let the tissue continue to develop and the organ to mature. Okay, it's just enough blood to actually feed the tissue. Okay, the rest of it's going through the circulation, through the hole. Okay, now when the baby is born, obviously we need the lungs to start to work. Okay, so the patterns of fetal circulation are going to really dramatically change. Okay, and again, about 50% of that birth weight is in that last 10 weeks, that last trimester. Okay, so you're going to get the neonate parting from the placenta. So we need to get that blood to circulate normally. We need to get the lungs to inflate, because at this point they're not really inflated. The only blood that's been going up there is just to keep the tissue from dying, okay, and allowing it to mature, okay? So with that being said, when you bring the baby out and you think about the old movies where they hold the baby upside down and smack it, right, make it cry, what happens when it cries? It takes in a lot of oxygen. Okay, it's actually the carbon dioxide that is built up that makes the lungs start to work. Get that rush in of the oxygen, okay? And that carbon dioxide is kind of built up in there, and it's now, the lungs are hopefully going to inflate, okay? What if those alveoli don't inflate? What if there's not enough, what is gonna inflate those? Surfactant, okay? If there's not enough surfactant, then we can actually add some, okay? But that is something that you really have to watch, because those lungs are not functioning. Now what happens to that hole? We need to close the hole, right? So we get that a flap coming down and closing that hole. However, we always still have a little indent there, okay? So that we can actually, you can actually see on baby, you can actually see an indent still there. But hopefully that flap closes. If the flap doesn't close, there you're gonna hear that third heartbeat sound, because that flap will flap, okay? If that doesn't close, you need to have heart surgery, you need to get that closed, because otherwise you're not gonna get any blood going up to the lungs and then we're gonna be in trouble, right? Okay, so we need to get that flap closed. Sometimes up to about 6 months, you can still hear a little bit of that flap, okay? And sometimes you can still hear a little bit of a third heartbeat in really tiny infants, okay? This is true of a lot of mammals, dogs, cats, babies, okay? You need that flap to close, okay? All right, again, that third trimester is where you get about 50% of the weight development, okay? And again, a lot of things are not really completed. Liver is not fully functional, and neither is the kidneys, okay? The kidneys, somewhat, okay, but not much. Joints are not ossified. The myelination of the nervous system has not been completed, okay? We are born more immature than most mammals, okay? If you live on a farm, if you have say a horse giving birth to a baby, if that baby is not up within an hour, you worry. They get up on their feet and they start to nurse within a couple hours, okay? With my sheep and my goats, if those suckers aren't up and we have coyotes around, we've got a problem, right? You need to get those animals up on their feet so they can get out of the way if there's a predator, okay? Which is why these kind of mammals are all up and going. Horses are kind of bottom of the pecking order when it comes to, predators. Sheep, goats, those are all animals that need to get up, okay? Even big cows will get up, okay? So we're really immature compared to that, okay? The respiration, again, this is the lungs. It's really stimulated to breathe by that CO2 accumulation, okay? Which is why the old doctors used to hold them up by their feet so that they would drain out, suck it all out, okay? And then they would smack them on the butt, which you can't do anymore because somebody would yell at you for that, okay? But you need to get all that sucked out and you need to get that oxygen in there, okay? So it's accumulation of the CO2 that causes the lungs to inflate. And again, it should start really spontaneously at birth. We've got to inflate those collapsed alveoli, okay? And this really is a lot of effort on the infant's part to inflate those lungs, okay? And that's why they really keep an eye on that, okay? There is what we call a neonate period. This is the first 6 weeks of life. During this period, we have, again, the heart and respiratory rates start to increase. Okay, hopefully within the first 6 to 8 hours, we have all of this going on, and they're watching them closely. The body temperature begins to fall because it's now in room temperature. Okay, we got to get that mucus and debris out because a lot of times babies will inhale that stuff. They'll inhale the meconium when they're being born, and you need to get that stuff out. Okay, the baby hopefully is going to start getting into a wake sleep cycle, hopefully. Okay, this will occur every 2 to 3 hours. This is 3 to 4 hours, but it's really 2 to 3 hours that they sleep. Okay, again, with the neonate is going to begin hopefully spontaneously breathing, CO2 accumulation. We've got to get those collapsed alveoli up, okay, and going and stabilized. okay? Because again, the lungs were not working, okay? The umbilical arteries, okay, are going to all become fibrous, and so are the veins here, okay? And then we have some ligaments also that are going to actually arise from some of the shunts that we had in place near the, especially near the liver, okay? You have that big hole, okay? Those flaps are going to hopefully fuse and close, and they leave the depression. What's a fossa? It's a depression. So it's an oval depression. Okay, that is left there, okay, in the septum. Okay, and again, the ductus arteriosus, this collapses also becomes a ligament in here. A lot of these shunts and ways in which we directed the blood and the stuff actually become ligaments when they start to become more fibrous. They fibrose. Okay. Cellular immunity appears very early in development, but is very weak. Okay, and hopefully the mother has been able to transfer a lot of her, especially IgG, through the placenta. Okay, but after birth, the mother's IgG rapidly breaks down. Now, breastfed are going to acquire some more antibodies through the breast milk, specifically the IgA, but there are some IgGs that can also come across in the breast milk. Okay, so obviously there's one point for breastfeeding. Okay, now with mammals, okay, everybody's immune system kind of develops a little bit differently. Okay, so let's take, for example, a puppy. How many people have had puppies or kittens? Okay, you have to go into the vet for the puppy shots or the kitten shots. Okay, why is that? Because we know the immune system in small animals like cats and dogs starts to develop to the point where they can actually respond to vaccines about 7 to 8 weeks. They're usually matured at 16 weeks, so one shot should be past 16 weeks. Okay, but in that interim, we don't know where that particular animal or baby is going to have their immune system mature enough to actually be able to handle vaccines. So that's why we give them multiple. Same thing with babies. Babies are about 6 months. You need to get those baby shots, okay? And occasionally you need boosters because we don't really know when that particular animal or baby is going to have an immune system that's mature enough to be able to handle the vaccines, okay? So that's why we do series of shots, okay? We also have thermoregulation issues. The infant has a very large surface area to volume versus volume, okay? And we need to really watch for thermo loss in here. And babies have what we call brown fat. It's deposited during the last weeks as a fetus, okay? And what the difference is in brown fat versus white fat. Adults have white fat, babies have brown fat, and brown fat has a lot of mitochondria in it, okay? So it makes a lot of ATP, and so brown fat is actually heat-generating tissue, unlike white fat, which is just kind of adipose cushion fat stuff. Okay, this is actually a metabolic tissue. Okay, now unfortunately, as the baby grows, it loses the brown fat and it's turned to white fat. Okay, there's actually a lot of research out there trying to turn adult white fat back to brown fat so we can all lose weight. Okay, I don't know that'll happen. Okay, but they start to lose this as and people talk about baby fat. Baby fat's brown fat. Okay, it accumulates subcutaneously and it retains heat. okay? But as this baby is maturing, it's losing its heat-producing fat. It's turning into adipose, okay? Therefore, they have difficulty in temperature regulation. So if you have an infant, what do? You put them in layers. So if they get hot, you start taking it off. If they get cold, you start putting it on, okay? Because they can easily get chilled quickly, okay? Or get overheated quickly, okay? And because as they mature again, babies are gonna lose their baby fat, their brown fat at different times, okay? So this is something that mothers have to really watch for. We also have to watch for fluid balance. Now this is very important because we've talked about if an infant gets diarrhea, or starts to vomit, it is potentially a serious medical issue, okay? If your baby has diarrhea, you go to the emergency room, zippo, okay? If it's vomiting a lot of fluid, not you just fed it and it just upchucked all over your shoulder, okay? That's not the same thing. We're talking about really projectile vomiting, really vomiting, not having to do with it had an air bubble and it just threw up all its milk on your shoulder, okay? There's a difference, okay? Because what is happening here is the kidneys are not fully developed. So they can have a very high rate of water loss very quickly, okay? And this can be deadly, okay? So this is something that you really watch on the babies, okay? And also feeding them on every couple hours because they can't hold on to a lot of that fluid for very long, okay? So fluid balance is potentially a life-threatening issue, both in infants and babies, but also in geriatric patients, okay? Because if their kidneys aren't working so well, you can get into this kind of trouble too, okay? Other systems with issues, again, the liver, the joints, myelination of nerves, a lot of these are still developing as we talk about babies maturing. Okay, so premature babies, they say anything under about 5 pounds now. And again, a lot of the issues that we see with preemies are going to be specifically the respiration, because the lungs are the last thing to develop. Thermoregulation, because again, in that last trimester, the last couple weeks, you got the 50% weight gain, which means you got the brown fat being deposited, okay? So you've got thermoregulation problems, okay? Again, kidney issues, digestion a lot of times, and again, obviously liver function. Okay, the liver is one of the last things, it's like the lungs to be completely developed and functioning. And in fact, a lot of babies are born jaundice, which would mean what? Liver's not quite working yet, okay? And you put them under bright lights and the liver starts to work. Now don't ask me how that works, I have no idea, okay? But it works, okay? But that is one of the last organs to be looking at, okay? So again, we've also got a very important issue called infant respiratory distress syndrome, okay? And this is where they don't make enough surfactant, okay? This is very important. It's probably the most common cause of death in premature babies, okay? The lungs have not produced enough of that pulmonary surfactant. The alveoli won't remain open. Remember that surfactant is like the inside of the grape, okay? Without the inside of the grape, the skin of the grape just sticks together, okay? And you can't inflate it, you can't breathe, okay? It needs a lot of energy to get that going, okay? So we do have, we'll put them under positive pressure oxygen, but we also can administer surfactant, okay? So this is a very important issue. Go back and read that in the lungs, know who the cells are that are producing surfactant, okay? Again, with the preemies, again, a lot of them have issues with organs not being fully developed, so a lot of them can have difficulty ingesting the milk, so some of them need to be fed through tubes. Again, the liver is not fully developed, so clotting factors can be an issue because that's where they're produced. Albumin, again, blood proteins produced by the liver. And again, they get the jaundice because they can't dispose of those biopigments very well, okay? So, again, the liver, okay? So, with that being said, we're gonna talk about birth defects. Now, when we talk about birth defects, most people say, oh, well, they're missing an arm or a leg or an ear or whatever, okay? There are birth defects that you can see, and there's birth defects that you can't see, all right? And sometimes those birth defects that you can't see don't show themselves until the child gets a little bit older, okay? So we're gonna talk about those, okay? So you can have congenital problems. These are primarily a result of an organ in maybe not completely finished maturing or not maturing correctly, or it's in the wrong place, okay? Something happens in that prenatal development, okay? Again, that first trimester is the most important because this is where most of this is going on, okay? This is probably, again, another very big cause for infant mortality here in this United States, okay? You can have external, internal, physical, or again, the psychological. And we'll talk more about the psychological in a minute. And then we have some genetic issues, okay? Obviously, mutations can cause a problem. DNA structure has not, you have something that caused the stress to the cell as it was dividing. You get a mutation in the DNA, and you're going to get problems. There are things that are called mutagens, which cause mutations. Mutagens cause mutations, okay? And they can be chemicals. There's a lot of viruses out there that can cause mutations, and radiation, which is why we don't do x-rays on pregnant ladies, okay, unless we really, really, really have to. Or we don't do them on little kids unless we really, really, really have to, okay? Because radiation can cause problems. Tetragens, these are environmental agents that can cause anatomical deformities in the fetus. And again, they fall into three major categories. Again, drugs, infectious diseases, primarily viruses. There are some bacteria, but primarily viruses. And then radiation, okay? The exposure during the first 2 weeks may cause a spontaneous abortion, okay? After that, again, that first trimester is the most important, okay? And this is really kind of scary because a lot of women don't know they're pregnant and they'll go out drinking or they'll smoke or they'll take drugs or whatever, okay? And that's when it causes the most problems. And then when they realize they're pregnant, they stop it, but it may be too late. Okay, so that's something to keep in mind. We do have a metabolic disease, a gene mutation here, Tay-Sachs disease. This is an inherited disorder, and it destroys the nerve cells in the brain and the spinal cord. It is a recessive autosomal mutation, which means it's not sex-linked, and it's recessive. Okay, so you can have carriers out there, and you have to have two mutated genes, one coming from each parent to get it. Remember what a recessive is. Okay, it's a mutation in the hexa gene that causes a deficiency in this enzyme, beta-hexaminidase A, which breaks down fatty acids in the central nervous system. So what happens is you get around 3 to 6 months of age, you're going to get usually some symptoms, but we can get what they call an infant form, one that's developed a little bit later, a juvenile form, or a late onset adult form. So depends on how mutated this particular enzyme is. Okay, you will see development of muscles slows down, weakens. You'll see some involuntary muscle twitching. This goes with the muscle issues, difficulty in swallowing, seizures. We see vision loss, eventually paralysis in most of the juvenile and infant forms. Late onset adult form, not always. It usually is a little bit less. The infant has a lifespan of about 4 years, juvenile usually into about their teens, and the late onset adult form, it depends on when it starts showing itself, okay? And again, it depends on how much of that hexa gene is an issue, okay? So there is no cure. It is typically found in Eastern European individuals. There is now genetic testing that you can examine that hexa gene for any changes that affect the presence and function of that gene, or you can have some blood tests, okay, that look at the level of that gene. If the gene is absent or not working, then you have what we call Tay-Sachs disease, okay? There are a lot of genetic testing kits out there, okay? Before I breed my dogs, I do all this genetic testing, which is really kind of funny, because I have Sussex Spaniels, and they're a dwarf breed, okay? So they're about yay big. They look like a fuzzy basset hound, except they're smaller, okay? And I did the genetic testing, and it came back, this dog may have short legs. Okay, it may have the dwarf gene. Yeah, and everything else was clear, but I was just chuckling. I said, yeah, well, okay. It has a dwarf gene because it's got short legs, okay. But there's a lot of genetic testing out there. So, however, most people, especially if they've had Tay-Sachs disease in the family history, will know about this and get tested, okay? So here is a little bit about what happens in Tay-Sachs disease.
Single gene disorders occur when the DNA sequence for a specific protein is missing or altered. Tay-Sachs disease is a metabolic disorder derived from a single gene mutation. Tay-Sachs was collectively discovered in 1881 by Warren Tay and 1896 by Bernard Sachs. Although they were describing the same disease, it was not until 1930 that it was identified as a metabolic disorder, thus naming the disease Tay-Sachs. Later, in the 1960s, GM2 ganglioside, the fatty acid responsible for Tay-Sachs, was recognised and named.
Tay-Sachs is inherited in an autosomal recessive manner. This means that 2 copies of the faulty gene must be inherited for the disease to be present, and that both parents must be carriers. Children of parents that are both carriers have a 50% chance of becoming heterozygous healthy carrier and a 25% chance to be either homozygous healthy or homozygous affected.
Tay-Sachs is a single gene mutation of the HexA gene, located on chromosome 15. Its position is 15q24.1. This means it's on the long arm of the chromosome at position 24.1. Beta-hexosaminidase A is an important enzyme found in the lysosome, which breaks down the fatty acid GM2 ganglioside. This enzyme requires the alpha and beta subunit in order to function correctly. The HexA gene is responsible for producing the alpha subunit, so a mutation to this gene is detrimental to the healthy functioning ability of the lysosome. A normal functioning lysosome allows the breakdown of the fatty acid GM2 ganglioside and for it to be disposed of. Carriers have enough of this enzyme to avoid symptoms. Without the proper functioning ability of this enzyme, the GM2 ganglioside fatty acid builds up in the brain and spinal cord, leading to cell death and the signs and symptoms of Tay-Sachs disease. Depending on the severity of the mutations on the HexA gene will depend on the severity of the disease.
Tay-Sachs disease can be inherited in 3 different forms, and as seen from the slide, 1 in 250 people of the general population are at risk of being a carrier. The most severe is the infantile form of Tay-Sachs. Symptoms are not shown until the infant is around 6 months of age, and at this time, development begins to become recessive in nature. There are less severe forms of Tay-Sachs disease, juvenile Tay-Sachs, which will show signs around 2 to 5 years of age, and late onset Tay-Sachs, which typically appears around adolescence or later in life. All forms of Tay-Sachs have no cure. The most common sign is the cherry red spot on the retina of the child's eye, as seen here, indicating excess storage of lipids. The child will eventually be unable to swallow or move at all, they will become blind, suffer from seizures and dementia, and be unable to breathe. The disease is very fast acting, and the child will die between the ages of 2 and 5 years, usually from respiratory failure. These photos show the rapid decline in children with the disease, with only 18 months between photos. A number of tests for diagnosis and screening single gene mutations, including Tay-Sachs disease. Carrier tests can be done by enzyme assay, screening for beta-hexosaminidase A levels, or DNA tests, screening for the specific mutation. Both are done by blood test. Pregnancy screening can be done by chorionic villi sampling, otherwise known as CVS, and is a procedure where some of the placenta is biopsied from the mother. This occurs around 11 weeks gestation. Amniocentesis, occurring around 16 weeks gestation, involves sampling the fluid from the amniotic sac. Two testing protocols can be employed: fluorescent in situ hybridization, otherwise known as FISH, which uses fluorescence to detect abnormalities on chromosomes, or a polymerase chain reaction, otherwise known as PCR, which is used to amplify a specific DNA sequence. These methods are used to test for chromosomal abnormalities, including single gene mutations. Assisted reproductive technology, otherwise known as ART, can be used in families who wish to conceive but are aware of a genetic or chromosomal disorder within their family. In a couple who are both known carriers, a type of ART, such as in vitro fertilization, can be used in conjunction with a pre-implantation genetic diagnostic test to ensure the baby does not inherit both of the faulty genes. This type of ART involves a genetic profiling of the embryo outside of the womb before implantation. Currently, for late onset Tay-Sachs disease, there is research into an anti-malaria drug called PMT, which has the effect on the body of increased hexa production. Regarding infantile Tay-Sachs, a recent discovery in Jacob sheep may allow further tests which are applicable to human infants, but until this time, there is still no cure or treatment.
Alright. So that is Tay-Sachs disease. Alright. So again, when we talk about birth defects, okay, we can get, there's a state, aneuploidy. This is a state in which a cell has an abnormal number of chromosomes, the presence of an extra one or a lack thereof. So it's a different number than should be in the cell, okay? This really, we believe, accounts for about 50% of spontaneous abortions, okay? Again, remember, you go back to the cell cycle and you have the checkpoints, okay? If the cell doesn't make it through the checkpoints, it usually undergoes apoptosis, okay? So this is typically where you're going to see things that would be not sustainable in life. We're going to lose it, and usually again in the first trimester, okay? If it goes beyond the first trimester, or depending on the mother's age, or maybe a known genetic defect like Tay-Sachs disease in the history, you can undergo amniocentesis. This is where you take some of the amniotic fluid and look for any kind of genetic defect, or you can go in and sample the chorion and look again, as you saw in the movie. These two are very common, and it just depends on when the mother wants to do this as to when they do it and what they're looking for, okay? Again, we detect this more in humans than any other species, and that is probably because animals tend to, if there's something wrong and the animal cannot make it through the end of gestation, they rapidly reabsorb the eggs, okay? So if you have, say, a dog that you got pregnant and there's something that is not allowing for that pregnancy to continue, that dog will reabsorb the eggs and you won't have any puppies, okay? And that's not that uncommon to happen, okay? So when we talk about things coming out or being able to be born, that's more common in humans than it is in these other species, okay? So again, it takes, again, those oocytes don't complete the meiosis until it is fertilized, okay? And again, we talk about age of the mother being an issue when you have pregnancy. It's also the age of the dad. Okay, now remember, males can have sperm all the way until 70s or 80s. However, that does not necessarily mean the sperm are healthy, okay? Women stop producing eggs somewhere around 40 to 55, okay? But when you start to get into the late 30s or the 40s, the chances of having an egg that has an issue are higher, okay? So you start to get into those high risk pregnancies, okay? And one of the issues is that the chromosomes are less able to separate during mitosis. Okay? So you end up with too many chromosomes in one egg and not enough in another, or something going on. Okay? And so we get what's called non-disjunction of the chromosomes. They fail to separate during mitosis or even the meiosis, the production of the fetus after it's fertilized. Okay? So non-disjunction is a big issue. Okay? We have 3 non-disjunctions of the sex chromosomes that actually are survivable. Okay? We have what's called a triple X syndrome. Now remember, the eggs only carry an X, and the sperm carry an X or a Y. Okay? So a normal pregnancy, the infant would be XX or XY. In this case, okay, the egg does not, the X's don't separate during the mitosis. Okay, so you end up with 2 X's from the egg, and then you get an X from the sperm. Okay, this is the triple X syndrome. We've also got Klinefelter syndrome, where you get the 2 X's from the egg, and now instead of the X from the sperm, you get a Y from the sperm. And then we have the Turner syndrome, where we have no chromosomes from the ovum, they all stuck together. Okay, they didn't come across, but we get an X from the sperm. Okay, so these are the 3 we're going to talk about. The triple X syndrome, again, 2 chromosomes from the egg, an X from the male. This is an XXX. This is a female, XXX. It's a female. It is a sterile female. And again, you do see some outward birth defects associated with this. But we also have things that we don't see. The brain is smaller than children of the same age. We'll see some speech and difficulty in a lot of understanding of speech, processing spoken words. We see a lot of coordination problems. Again, we're hitting, the Wernicke areas, all those areas. Okay? They tend to be very tall, much taller than other girls. And a very interesting telltale sign is a curved pinky finger. Okay? I don't know where that comes from, but it's there. Okay? Curved pinky finger. They do have a normal life expectancy with this one, but they do have seizures, potentially from the brain abnormalities. Okay? And then they do have kidney function problems. Okay? So this is a triple X syndrome. It is survivable, and they live a long life. The Klinefelter syndrome, again, we get the 2 X's from the egg, the Y from the sperm. Okay? This is, we've got an X and a Y here. This is a male, a sterile male. Okay? Because he's going to get undeveloped testes, because we got one too many X's in there. Okay? And this one often is not diagnosed until you hit puberty. Because what starts to develop in puberty is it has very sparse body hair, very long arms and long legs, and we start to see from the 2 X's, we start to see some female genitalia. Okay? The undeveloped testes, because again, it was getting some of the turnoff of, because you have the Y in there, so you get some of the turnoff of the female, but not all. So you actually have a little bit of both going on. So we're going to get undeveloped male reproductive organs, and then we're going to start to see some enlarged breast. They're very tall, and again, this one is sterile, okay? But we don't see this development until puberty. Okay? But it is survivable, and they do have a normal lifespan. Okay, and then we have the Turner syndrome. This is where we get an X from the sperm, we get nothing from the egg. Okay, this is a sterile female because there's no Y there. Remember, the Y turns off the presence of the Y, the presence of the androgens, makes it a male, turns off the females. So we don't turn off the females, okay, we have the X still there, but it is sterile, okay? This one is interesting because they get a very big, thick, they call it a webbing, a neck here, okay? It's very clear, this is very characteristic of Turner syndrome. It's clinically diagnostic really to see this big, thick webbed neck, okay? They have another interesting thing, which is a shortening of the metatarsal bone, okay? So they get a lot of foot pain. Now we can treat some of these symptoms because they've got some shortening of some bones here by giving them some growth hormone. We can give them some estrogen replacement so that we can regulate a menstrual cycle because they do have female organs, okay? But symptoms can be treated and that we can't change anything, okay? But the symptoms can be treated, okay? So they do have a very childlike appearance. They have underdeveloped reproductive organs because they only have the one X. Okay, so not enough hormones. They're going to get an undeveloped breast, little or no pubic hair. They become very, very short. Here's a picture of two sisters here. They have a lot of ear infections, which indicates the immune system is not normal, okay? Males and females have different immune systems, okay? Typically, we see more autoimmune diseases in females. They have more active macrophages and phagocytes. Males, we see more bacterial infections, okay? Because they don't have that active phagocytes, okay? So in somebody that doesn't have a normal female immune system, it's going to switch over to become more like a male immune system. Hence, we're going to see a lot more infections, bacterial infections. We're also going to see minor eye problems. Okay, this is about 1 in every 2,000 or 2,500 births. We have kidney abnormalities, heart problems, thyroid problems. Again, these are things that are not seen on the outside, and these are considered birth defects. Okay, this is a reduced life expectancy. A lot of this reduction in life expectancy comes from heart problems, kidney problems, or infection issues because of the immune system. Okay. Then we can also have the non-disjunction of the autosomal chromosomes. So we just talked about the sex chromosomes. These are the autosomes. So these are not the X and the Y's. This is everything else. And there's only 3 that are survivable. Okay? We can get an extra copy of gene number 13, 18, or 21. The rest of them are not survivable. Okay? And we call it a gene overdose. So trisomies, if you get in 3 chromosomes instead of 2, on anything other than 13, 18, or 21 are not going to be survivable. Okay? Even though 13 and 18 are survivable, most of them don't make it long past birth. Okay? And a lot of them will be the stillborns that we hear about. Okay? A lot of this is very severely deformed. And most of them aren't going to live even past infancy, though they are born. Okay? Trisomy 13 is called Patau syndrome. Okay? And some of the characteristics that we see, again, we do see in these trisomies, we do see some outward appearances that are changed. Okay? But there are some, kidney, brain issues that we don't see that are there. Okay? This one has a very, it's interesting, their big toe is flexed, and they have a very prominent heel. They also have very clenched hands, okay, overlapping fingers, and they have kind of a deformed ear, okay? They have a big, what they call an occiput, big round area back here, okay? And a lot of these have cleft palates. Cleft palates usually gives us an indication there's something going on underneath that we don't know about, okay? So there are some outward indications that there are some issues with this. And again, this Patau syndrome, most of them don't make it up to a year. Okay. And then we have trisomy 18, it's called Edwards syndrome. This is little Edward. Okay, this is what he was named for, little Edward. This is about 1 in 3,000 births. Now this number goes up as the mother ages and also as the father ages. Okay? But again, we will see some things that are outwardly shown, and things like brain abnormalities, heart defects, kidney problems that we don't see. Okay? This one has, again, a cleft palate, cleft lip. They have what we call rocker feet. Okay? Hearing loss, feeding problems. Again, 90% of them are miscarried or stillborn, and then the rest of them usually die within that first year, most of them within the first couple days. And this is Edwards syndrome. So we've got Patau syndrome, we've got Edwards syndrome. Okay? Now trisomy 21, most of us know about. This is Down syndrome. Okay? This is the most survivable of all the trisomies. Okay? And a lot of us know or have come in contact with Down syndrome children. Okay? They do have impaired physical and mental development. They have that very flat-faced, okay, with a very flat kind of nasal bridge and kind of slanted eyes. So they're very easy to identify, okay? They've got the folds at the medial corners of the eyes, okay? And it occurs in about 1 in 800 births. Again, this does tend to go up as we age, okay? And this is one that a lot of people will check for a woman that is over the age of 35 and she's giving birth, okay? A lot of these, again, the immune system is got some issues here. So a lot of them will die from infections, abnormalities of the kidney and the heart. And what we're seeing now, where these children are living, used to be that they would die in their 20s. Now they're living into their 40s and even maybe into their 50s, because we can deal with immune issues and we can deal with heart and kidney issues. Okay? However, we're now seeing a lot of early onset Alzheimer's. Okay? So we'll lose most of them in the 40s and 50s to late onset Alzheimer's. Okay? And again, here's a karyotype here, okay, where you see, this is a female, okay, and you can see there's 3 down here, there's pairs. All the chromosomes have pairs, except this one down here has 3, okay, and that is your 21, okay. And again, this one also has that kind of rounded kinked pinky, and then the folds at the eyes. So they're fairly characteristic. Okay. So again, when we talk about birth defects, we talked about the sex chromosomes, we've talked about the autosomal chromosomes, but we've got some other things that we need to talk about. Anything that, all the tetragens, anything x-rays, we talked about chemicals, but infectious diseases. Herpes can cause birth defects, rubella, gonorrhea, and toxoplasma. Okay, so how many of you have cats? If you're pregnant, don't clean the litter box. Okay, because cats can carry, especially if it's an indoor-outdoor cat, and they can carry toxoplasmosis. Okay, and then you can get problems if you are pregnant. Okay, which is a good excuse to make your husband in the litter box. Okay, so there are infectious diseases that can actually cause some problems. Okay, again, when we're talking about things outside the body, not the genetics, but the things outside the body that are going to affect this pregnancy, it depends on what part of the pregnancy you're in. Again, the first trimester is the worst. right? 'Cause everything is multiplying, okay? Also the dose, okay? When we get sick, okay, it depends on, again, the dose of whatever you're taking in. So let's say, somebody comes in here with the flu, okay? If you are really up next to them and you're breathing them in as they sneeze or cough on you, then you're going to get a lot more of the virus than if that person is sitting in the back, not getting near anybody and you're at least 6 feet away from them. Because most viruses go in to the ground. Okay, so 6 foot is a good distance. Okay, 8 foot's better, but you know, most viruses don't go very far in the air. Some will. Some will remain a lot on tabletops, which is why we clean the tabletops in the lab. Okay, washing your hands is a good thing. But a lot of it depends on how many virus particles you come in contact with, okay? Or how many bacterial particles you come in contact with, okay? Some things like Ebola, you only need 1, okay? Other things like the flu, you may need thousands in order to get it. And as we go through, like for example with COVID, pathogens don't want to kill their host. So, like COVID, it's mutated, and now it's less likely to kill you, but it's much more transmittable. They want to transmit, but they don't kill you. What's the point? If they kill the host, then they're not getting reproduced, right? Okay? Now, if you have something that's not able to get past fast enough in a population, because it's killing the population, it's never going to get, have a foundation in that population enough so that it actually mutates itself. Things like Ebola that are so deadly, rabies in humans that are so deadly that it's not gonna ever stay around long enough to get, to change and mutate, become less virulent. Okay, so there are things that won't ever, but that's because we're not the normal host for those things. Okay, so a lot of it depends on the dose, and again, the dose also depends on how long you were in contact with the virus. Okay, so again, that greatest vulnerability of all of this is that first trimester when different organs are reproducing and maturing and developing. Okay, back in the 60s, okay, there was a drug called thalidomide. And this was used as, it's a sedative, and it was taken early in pregnancy to help women sleep, insomnia. It also helped with morning sickness, okay? Unfortunately, okay, it has a very big impact on limb development, so it caused babies to be born without arms and legs or deformed arms and legs. There's a little boy with deformed arms and legs. But we also saw defects in heart, ears. This little guy doesn't have deformed ears, but little kind of pointed ears, and intestines. Okay, they took it off the market in 1961 because of this issue. Okay, but it can be still used in leprosy. What's leprosy? Bacterial infection. Yeah. Okay, so it still can be used in leprosy to kill the bacteria. Okay, but it is not used in pregnant ladies because this created a big issue. So people born before the 60s saw a lot more of this. Okay, luckily I was born after that. All right, so alcohol, I think we all know alcohol is one of our biggest, causes more birth defects than any other drug. Okay, into the fact that we know we have what's called fetal alcohol syndrome. Okay, now we're going to talk about abuse or too much of something, but I'll tell you that depends on the mother. It also depends on what part of the pregnancy she's in. Again, the first trimester is the worst. Okay, but I don't drink that much except maybe holidays or if I'm out with the lady friends or whatever. Okay, so I don't drink that much. But you do pick up a tolerance, okay, to alcohol. So an alcohol abuse for me might be 4 drinks on a regular basis. Okay, give me 2 and I'd probably be okay. All right, I'd be giving you all A's. All right, but in some people that means a lot more. So you have to remember that this is kind of individual. Okay. So we know in fetal alcohol syndrome they have small heads, malformed facial features. We have some cardiac issues, and we have things that we're just now starting to really realize in the last 15 or 20 years is some CNS problems, stunted growth, and a lot of times when we see this stunted growth, we also see behavior problems. Okay, there's something in here about the growth of body and the brain and the central nervous system. Kind of goes hand in hand here. Okay. Now I can tell you the boss that I worked with up in Seattle, okay, for many years, he was an MD, I was a PhD, his wife was an RN, and when they married, they both had kids from other marriages, and they ended up with like 10 kids, okay, but they loved kids, so they adopted the cutest little boy you have ever seen. Little red hair, bright blue eyes, the cutest little boy you've ever seen, okay? He started into puberty, and they started seeing some problems. Okay, at the age of 12, he approached his mom with a knife, stole the car, and took off. Okay, they went back, and this was a closed adoption, and they got the courts to open the adoption. Both parents were alcoholics. Okay, so he grew up, he had no regard for authority figures whatsoever. Okay, he did not recognize police, parents, anybody. Okay, he was eventually institutionalized because he was potentially a threat to everybody. Okay, but not until he started into puberty did they notice any problems. Okay, this was obviously fetal alcohol syndrome. Okay, we do know that cigarette smoke contains a lot of stuff. Okay, we see a lot of ectopic pregnancies, fetal and infant mortality in people that have cigarette smoke. Secondhand smoke is also an issue. We also see cleft palates in women that have smoked during pregnancy, okay, and cardiac abnormalities. Okay, so cigarette smoke, secondhand smoke, I think we all know that. Okay, it's not as bad as it used to be because we have filters on cigarettes, but it's still an issue with pregnancy. Okay, now we'll talk about marijuana in a minute because we don't have filters on those things. Okay, there we go. So when I was teaching this years ago, when marijuana became legal in the state, one of my students came up and said, well, you're going to talk about marijuana, aren't you? And I said, well, okay. So I went home and made some slides. Okay. All right. So this is actually, interestingly, has been studied since the 60s. And we all know it's THC that gives us that high. But remember, when you're smoking a joint, there is no filter on there. So you are inhaling a lot of carbon monoxide, okay, tar, and all of that stays behind in the lungs. And why is carbon monoxide an issue? What does it bind to? Same place the oxygen does, but tighter. Okay? You're going to have to put oxygen under pressure to push that carbon monoxide off that iron. Okay? Because it really binds tighter, which is why when you hear people have carbon monoxide poisoning, we talked about that, you're putting your generators too close to the house or heating your house with the grill, which happens every year in Seattle, in somebody's apartment. Okay? That becomes an issue, obviously. Okay? And I always laugh. We were doing clinical trials and people would come in and they test positive for marijuana, and since we're doing drug trials, that's a no-no. And they would be like, I haven't smoked in 6 months. Okay, and it's fat soluble. It stays with you 6 months, 8 months, 12 months, usually about 12 months it's gone. Okay, but you can test positive up to 6, 8, 10 months. Okay, so just keep that in the back of your mind if you are smoking pot and you have to take a drug test. Okay, you'll come up positive. Okay, and people used to come in, oh, you can't tell I smoke pot. Well, yeah, you can't finish this full sentence, but okay. We'll talk about marijuana. Okay, it's not a benign drug. It just isn't. And when we talk about pregnancy, it's even worse. Okay? This was a big study that was done, about 12,000 babies. And what we found in a lot of these studies is that lower birth rate. Okay? So they have growth restriction. Remember what I said about growth restriction? Okay? We also have some problems with other things. Okay? In this case, out of 420,000 live births, there's a higher risk of them being in neonatal intensive care. Okay? If mom was around the secondhand smoke or smoking it herself. Okay? In a Brazilian study, these newborns were irritable, less responsive to calming, cried more during exam, they were jittery. What's that telling you? Mm-hmm. Okay? And then again, pregnant women who smoked or smoked through delivery have a much higher risk of ectopic pregnancies or problems during the delivery than if you quit during that first trimester when everything is developing the baby. Okay? So there are some issues with mom too. Okay? There also have been some studies now where they've started to follow these kids long term. Okay? And they started looking at 3, 10, and 14-year studies, and they found that these kids had learning disabilities and they had emotional issues, specifically aggressive issues, which kind of follows along with the fetal alcohol syndrome. Okay, that's what we see in fetal alcohol. Increased depression. Okay, so we're seeing the lower size, okay, but also we're seeing these behavior problems. That's kind of goes hand in hand with it. Okay, so it's not a benign drug. Okay, alcohol, on the other hand, is still the highest risk for birth defects, including physical and then mental and behavior. Okay, cocaine in comparison is a lot higher risk for admission to intensive care because these babies are usually addicted when they come out. So you need withdrawal, you have some toxicity, but you have that lower birth rate in there. So that birth weight is an indication there is something going on. Okay, we do see growth retardation, shorter, smaller head circumference. There's another indication that things are going on. And studies suggest, but they haven't been followed with cocaine for some reason, behavior, mental development extend beyond childhood. Okay, so they're not, even though you don't see the physical differences, there are internal problems that we're seeing, especially mental and behavioral problems that we're seeing with these. Heroin, okay, has not also been associated with birth defects. Now again, when we say birth defects, we talk about what we can see, physical stuff. However, they are known to be, have withdrawal, intensive care, and it's very controversial because it hasn't been studied very well on the mental and physical issues. Okay, we see it in cocaine, we see it in marijuana, we see it in alcohol, we see it potentially in heroin, and now we probably see it in fentanyl. Can't even imagine what fentanyl does. Okay, but the whole bottom line is if you disrupt that normal fetal environment, I don't care what it's for, marijuana, cocaine, alcohol, whatever, you're putting that pregnancy at risk. Short-term and possibly long-term development. Short-term, things that we see, long-term, things that we don't see. Okay? We'll stop here and we'll pick this up on Wednesday and finish up. Okay? Remember, those that are coming to the lab exam,